Hi there, I'm Aaron Farberg, and I'm a board-certified dermatologist and Mohs surgeon at Baylor University Medical Center. Today, we're going to be talking about integrating genomics into your clinical practice, and this talk is sponsored by Castle Biosciences. For disclosures, I am a investigator on many of the research studies going on at Castle Biosciences. I also wanted to say thank you to the Wisconsin State Derm Society for having us today. Quick story. So I grew up on the north side of Chicago, but my parents were actually from Milwaukee. So not surprisingly, we still kept many of our doctors across the state line in Wisconsin because, as my mom would always say, all the best doctors are actually in Wisconsin. So here's the workflow that many people are already know and are aware of with Castle and their gene expression profile test. And we'll just quickly go through the workflow. So you have a tissue of interest, whether that be melanoma, squamous cell, or a melanocytic lesion that you're unsure of. You acquire that tissue, usually from paraffin-embedded blocks. You isolate the RNA, do RT-PCR to amplify it, and then analyze a variety of genes to determine an outcome, which will result in something like a result A, B, or C, which you would then expect to have some sort of clinical impact. And that is sort of the layout that Castle Biosciences has been an industry leader of and established a variety of useful tests in this manner. And so the first one we're going to talk about is it's the DiffDx test. It's for suspicious pigmented lesions. And this is their latest test. We're only going to talk about it for the next 5 minutes or so because we're also going to get into the squamous cell and cutaneous melanoma tests for the majority of the talk. So for suspicious pigmented lesions, this is an important clinical problem that we're dealing with regularly, every day. Over 2 million biopsies occur every year in the US for suspicious pigmented lesions. And fortunately or unfortunately, over 100,000 of these are invasive malignant melanomas. So we're doing a good job identifying these lesions. Of course, we'd always like to do better. But not every lesion is so straightforward. There's a number of difficult to diagnose melanocytic lesions, and these can be challenging to our derm path colleagues. Up to 300,000 lesions cannot be confidently diagnosed with simply routine H&E. And so here's the workflow that is kind of laid out for the management of these difficult to diagnose, or I just say melanocytic lesions in general. So you have your biopsies, and usually you can put them into one of two bins. They're either definitively melanoma, which is across the top there, and that's not the majority of the lesions, but thankfully we can diagnose those and proceed with treatment, usually wide local excision or Mohs, and then decide what sort of management is required thereafter. On the bottom side of this chart, you can see, these lesions are definitively benign, and that's the majority of these lesions, and then no additional treatment is needed, and you can have routine follow-up. But there's that middle category where, you can't necessarily make a certain diagnosis, particularly after, just a simple H&E. And so these are the lesions that the DiffDx test is quite helpful with, and we'll talk a little bit about that. So what do you do with those difficult to diagnose lesions? Well, I'm not a derm path, so I didn't make this chart, but this is usually what you go to is these ancillary tests, right? Often you're going to get a second opinion or a third or a consensus panel. You're going to do other ancillary tests such as FISH or CGH, or you're going to run a gene expression profile. And Castle has the latest one, which is a 35 gene expression profile, the DiffDx test. And real quick, here are the metrics. Essentially, they've got great sensitivity, great specificity, excellent PPV and NPV, but importantly is this really small intermediate risk. And the idea is that, when you're already running across these difficult to diagnose melanocytic lesions, having a large intermediate area just isn't all that helpful, particularly on the clinical side of things. Because if you think from a clinical side of clinical perspective. If I get one of these lesions and we're still unsure, then you're likely to treat it as the most dangerous diagnosis in the differential. And so by having a smaller intermediate risk, I think it leads to more clinically actionable results. Now, there's actually some special considerations for different lesions with the DiffDx test. So notice that during the test development that there were some lesions that actually were even a bit more difficult, particularly those with spitzoid features and epidermal lesions. They had different patterns of gene expression. And for that reason, and to really improve the test itself, there are different switches, the spit switch or epidermal switch, to really hone into those particular lesions and how the gene expression profile algorithm can be maximized. And remember, these tests, the DiffDx test is not there to replace a dermatopathologist. They have to, the data that the test produces has to be interpreted within the context of all other clinical laboratory and histopathological information. All right, now let's move on to melanoma prognosis and risk of recurrence and metastasis. So here we have, here's the problem, right? So when we think about staging for cutaneous melanoma, we do a fairly good job, but it's not perfect. And what you see here over on the left is that the majority of patients with cutaneous melanoma are diagnosed at early stage disease, stage 1. These are thin melanomas. However, a good chunk of the mortality occurs within these thin or early melanomas. 26% occur within stage 1. And so one would think that the prognostic accuracy of these staging systems could be improved, particularly for the improvement in management of our patients. And here's another example of that. When you look at AJCC version 8, and you can see when you compare the 2B and 2C data, the 3As actually do better with their melanoma-specific survival probability over 10 years. And so these lines are crossing, which just reveals the limitations of our current staging systems. Not saying they're bad, they're actually quite good, but how can we improve them even further for the betterment of our patients? And that's where the DecisionDx melanoma test really comes in. It's a 31 gene expression profile. It was developed to assess risk of recurrence independent from the traditional clinical pathologic factors using, obviously, the tumor's biology. And so Castle developed the test in the same way it develops its gene expression profiles. You take a patient with melanoma stage 1 to 3, you run it through the algorithm, and it produces a variety of risk scores. You have class 1 or 1A, which is actually the lowest, 1B and 2A, which is an intermediate, and then you have class 2B, which is the highest risk for recurrence or metastasis. And here are all the Kaplan-Meier curves. Many people have already seen a lot of this data, and I put it up here really just to show that we've had consistent results for recurrence risk prediction across a variety of different studies, both archival, prospective, and even later on, I'll show you some meta-analyses with over 2,600 patients. And that's really important, is multiple studies, multiple authors, multiple patients have been used in these studies to show the strength and validity of the DecisionDx test. Now, there's one exciting study that was just released a few weeks ago. It was showing the utility of the 31 GEP for predicting outcomes in cutaneous melanoma. This is the largest prospective, and it's an independent study to date with over 383 patients. And this was done at Oregon Health and Science University with patients from 2014 to 2020. And this is really exciting because this is really the gold standard when it comes to these sorts of validation studies. And it was also performed at a highly respected institute. The median follow-up was 32 months. And they also looked at things like recurrence-free survival and distant metastasis-free survival. And here are the Kaplan-Meier curves, and essentially what they're showing is that you did have nice stratification between those that were class 1 and class 2, and that the 31 GEP score, the class identifier, significantly correlated with recurrence and distant metastasis-free survival. Recurrence rates were higher for class 2 than class 1, 23% versus 5%. And also, sentinel lymph node positivity was significantly lower in patients with a class 1 versus class 2. Now, this kind of jumps all around, but in utilizing this test, you can use it to determine your risk for recurrence, but also sentinel lymph node positivity. And again, here you can see that the class 1 had only a 6.4% sentinel lymph node biopsy positivity, whereas the class 2 correlated with a much greater chance of a positive node. Now, what's even more important is that even if you're going to proceed with a sentinel lymph node biopsy, we know that the vast majority of those end up being negative. However, the DecisionDx melanoma test still provides additional data. I know my patients, even after they have a negative node, it's not like we just stop watching them. No, we're still worried about recurrence or eventual mortality. And here you can see that even those with node negative, a node negative status, the class 1A and class 2B really helped identify those that were going to be at high risk of recurrence or not. So the paper also put forth 4 proposed uses of the DecisionDx melanoma test that we'll cover. So the 31 GEP test can be used to identify patients who are GEP class 1A and node negative, and therefore at particularly low risk of relapse. And these patients can be followed perhaps just by dermatology, as their real greatest risk is of a second primary. And the 31 GEP test can be used to identify patients who are sentinel lymph node negative, but still at higher risk for relapse because of a high GEP class 2 score, even though they may be originally staged as a low stage. And the 31 GEP test, combined with patient age and tumor thickness, can help identify these patients who may then elect to forego the procedure because of personal choice or comorbidities. And we'll get into a little bit more of the data regarding that point in a few slides here. And there was also a small retrospective series that suggested that the GEP class separates out subsets of patients with 3A melanomas by recurrence risk, which may help guide medical oncologists in figuring out which patients could benefit from adjuvant immunotherapy. Now, here's one of the meta-analyses. There's actually 2 that are out. This one was recently published in JAD, and it's the largest cohort to date with 1,479 patients. Systematic review. What did it show? Pretty much what all those other previous Kaplan-Meier curves had showed, and that the DecisionDx melanoma test was independently validated and one of the most important predictors of risk. And here's one of the charts that came out of it, and this is one of my favorite slides, right? So here it's showing melanoma-specific survival, and if you were to just look at AJCC staging, there's the black dots are your percent chances of melanoma-specific survival. But when you layer in the class scores from the Castle test, you can see, well, gosh, if you end up with a 2B, you're actually even changing your staging. And if you're a class 1A, again, you're actually finding that you're changing the staging again. And so this is what the GEP test can actually do. It really refines what every patient's personal risk is. And again, here's, I jumped ahead with the slide from before, but here's the actual outcome, and you can see a nice stratification within the cohorts here across all the classes. And the GEP class 2B result had the highest hazard ratio even compared to sentinel lymph node biopsy. Now, this is a really great table, and this is what's in the new report that Castle now produces and releases when you order one of their tests. What's really nice about this is on the left, you'll see the AJCC staging information, what the 5-year melanoma-specific survival is for that staging. But on the right side, you get more specific and more personalized information along with the outcome of the 31 GEP, whether it be 1A, 1B/2A, or 2B. And you'll see the column, the 5-year MSS, that's how it refines the AJCC stratification. But, my patients care more than just whether or not they're going to, possibly live or die. They also care about how is this disease going to impact them later on. Information including whether or not they're going to have a metastasis or a recurrence. And that's where the Castle test really helps identify personalized information. And that's what those last two columns are. And you can see it varies quite a bit. So you have a stage 1 melanoma patient, and whether or not they have a 1A result, they'd have a 98% chance of not having a recurrence, or they actually have a 24% chance of having a recurrence if they're a 2B. So that's personalized information that I know my patients appreciate. And so what about thin melanomas? Well, this was another quick study that was done looking at tumors less than 1 millimeter. Essentially, even in the thin tumors, you also had good stratification across the different class scores. And again, the GEP 2B score had the highest hazard ratio for risk. Now, there's something called, a chain of evidence, right? And we all just assume in the oncology cancer world that if we're able to identify cancer earlier in its stage or earlier in its progression, that will obviously have better outcomes. But that isn't always the case. And so a strong chain of evidence needs to be established. And this was actually a recent publication that really added to that chain of evidence for how and why and where you'd actually utilize the Castle test. And the idea is that if you can identify patients at higher risk for recurrence or metastasis, then you can actually treat them sooner and hopefully achieve better outcomes. And this paper actually showed that. It was a single institution retrospective data review of 353 consecutive patients with stage 2B and stage 3 melanomas. And they wanted to know is if you did some sort of imaging, if you used imaging to identify which patients possibly would have a recurrence sooner, would that actually lead to better outcomes? And they utilized a variety of different imaging techniques, including CT, PET, and a combination of modalities, because we all know, depending upon the institution you're in, they're going to prefer different imaging modalities. And essentially, the study completed that chain of evidence, showing that if you could identify asymptomatic detection of recurrence in melanoma is actually associated with better outcomes. Of course, we'd love to see, a better curve than that, but the point is that we're able to identify these patients earlier on and get them treatment sooner, and hopefully we'll get even better treatments as time goes on. Here's another study. I know we're kind of jumping around, but Castle Biosciences has been very busy in building their plethora of data to support these tests. This was a paper that was published in JCAD not too long ago at the end of 2020 by Dr. Quatra and Dr. Leachman. It identified a clinical workflow for the use of the 31 gene expression profile test to align it within the NCCN guidelines, which is what many of us already use. And importantly, it was established by an expert panel that was aware and is user of the gene expression profile test. And so they were the best group to understand how to adapt this in a clinician's workflow. And one of the important points is that this test is utilized in a shared decision-making model, right? It's between the clinician and the clinical team and the patient. Let's go over some of the case studies. This is case study 1. We have a 34-year-old woman with a newly diagnosed melanoma on her right arm. It's a 0.6, and there's really no other bad or aggressive features, right? So what do we do with this patient? It's a stage 1A, it's a T1A. Well, we cut it out and we move on. But for this patient, well, they were actually a class 2B. The DecisionDx was a 2B, which is telling us that this patient has a very high risk for recurrence or distant metastasis, as well as potential mortality. So knowing that, her 5-year RFS, DMFS, and MSS actually aren't what we would expect another stage 1. And so what the clinical team did was the patient was referred to a medical oncologist for high-intensity surveillance. The patient received a CT scan that was initially negative, but on 6-month follow-up actually showed a lesion that was biopsied and ended up being a metastasis. Patient was then started on immunotherapy and continues to do well several years later. So again, this goes back to that solid chain of evidence. If we can identify patients with asymptomatic metastasis earlier on, then we can improve their outcomes. All right, let's talk about melanoma prognosis and the likelihood of sentinel lymph node positivity. Right, so how are our cutaneous melanomas patients currently selected for the sentinel lymph node biopsy procedure? Well, if you're following the NCCN guidelines, then you're looking at the risk of positivity for a sentinel lymph node biopsy. And these numbers didn't just come out of thin air. They actually came from the MSLT1 study. And so if your risk of a positive node is less than 5%, then there's no need to recommend the sentinel lymph node biopsy procedure. If it's between 5 and 10%, then you'd consider it, and greater than 10%, you'd actually recommend it. But the problem is with this procedure, the overall rate of sentinel lymph node positivity is about 12%, which means the vast majority of these patients are undergoing this procedure, which isn't offering them necessarily any benefit. So there's obviously a need to identify patients that could actually benefit from this procedure, and perhaps those that have a lower risk of having positivity can actually safely forego the sentinel lymph node biopsy procedure. And so again, this just kind of highlights what the previous slide was saying. Majority of patients are negative, and MSLT1 has already demonstrated there's no benefit to the actual patient. The false negative rate for nodal recurrence is between 5 and 21%. And let's also not forget that the sentinel lymph node biopsy procedure is not without adverse events or complications. And even at a rate of 11%, some people could argue, well, gosh, at my institution, it may be lower, but not everyone's able to go to the top tier institutions. And so the complication rate, I think, varies across the nation. And, Castle isn't the only one that's trying to do this. There's a variety of nomograms out there that are trying to better identify or predict which patients would actually benefit from a sentinel lymph node biopsy. The thing, though, is that what those other prediction tools are using are the same clinical pathological features, which they are helpful and have been useful. We all use Breslow thickness, but what about looking at a patient's actual tumor biology? That would be even more objective and could potentially guide treatment and management even more accurately than the clinical pathologic features. And that's what the DecisionDx melanoma test really can help do, right? So this kind of goes through a workflow. You're diagnosed with a cutaneous melanoma, and I'm coming across a variety of questions. What am I going to do for their management? Well, what that comes back to, what is their risk of recurrence? That's going to help determine what follow-up, what imaging, what referrals I'm going to select. And what about what's the likelihood of sentinel lymph node biopsy positivity? That's going to help determine whether or not I'm going to send this patient for a sentinel node or not. And that's where this new integrated test result from Castle Biosciences, which was also just released a few weeks ago, you're actually going to get an integrated 31 GEP result, which tells you your patient's actual predicted risk for sentinel lymph node positivity to help you determine whether or not you'd consider or potentially forego the procedure. And so how is this test further enhanced and developed? Well, I used two large cohorts of almost 1,500 patients each, 1,421 in one study and 1,690. And so how these tests are developed and worked out is that you take a training cohort where you develop the algorithm and the test, and then you have to validate it on a completely separate group, an independent validation cohort. And so fortunately, since Castle has a number of these cohorts and has been collecting this data for many years, they were actually able to come up with a very accurate, they're calling it the I31 GEP score. And we'll show you how that can help you with your patients. So again, with the training cohort, they looked at a variety of different variables. They looked at Breslow thickness, ulceration, mitotic rate, age, sex, whether it was a regression, microstaging, TILs, lymphovascular invasion. They looked at all these different characteristics and said, okay, which of these should we incorporate into the algorithm in order to really identify which patients are better to identify the absolute risk of sentinel lymph node positivity. And so with this new algorithm, it includes the 31 GEP score, as well as Breslow thickness, ulceration, mitotic rate, and age. It's not that the other characteristics weren't important, they were, but they came along with these factors, and these were the ones that actually had an impact on the risk for the patient. And then the algorithm was validated on a large independent cohort. And so that's how we get the new I31 GEP result. And we'll show you, this is the test report. So there in the center, you'll see exactly what the percent is, the likelihood of sentinel lymph node biopsy positivity for your patient. And it also highlights all the other patient-specific factors, as well as the 31 GEP score. And here it is just highlighted so you can see it a little bit larger. This is what the new report looks like. This has been fantastic for me, and when I get to sit down and talk with my patients with determining what their risk is and why we're making the clinical decisions that we are. So here's a patient vignette. Again, we have a patient with a T1B melanoma, 56-year-old 0.5 melanoma. There is ulceration, but no mitotic rate, no other high-risk features. So with this patient, you'd see that the likelihood of a sentinel lymph node positivity lies between 5 and 10%, which is a tough area. Some patients would send this patient or some clinicians would send this patient to the surgical oncologist, where they would most likely then get a sentinel lymph node biopsy, or at least have that discussion. And some may not. You're right in the middle. But when you run the Castle test, if you have a class 2B score with a 31 GEP of a 0.76, which again, we're not just cherry picking the highest extremes for the sake of a vignette, but if you have a class 2B score with a 0.76 GEP, then your likelihood of sentinel lymph node positivity is 13.4%. This really helps me lean towards the belief that this patient really should be recommended to have a sentinel lymph node biopsy. Now, on the contrary side, if you get a class 1A result, a 0.12, your likelihood of sentinel lymph node positivity is 3.93. So in this instance, it's less than 5%. I'd have a discussion with this patient and say that, in your instance, in this situation, we could forego the sentinel lymph node biopsy. So that pretty much covers the melanoma side of things. We're going to move on to cutaneous squamous cell carcinoma. We're going to be talking about prognosis, determining the risk of nodal and distant metastasis in patients with cutaneous squamous cell with one or more high-risk factors. And that's the new Decision DX SCC test by Castle Biosciences. So we all know that melanoma is a serious and scary and bad disease when it comes to mortality. But when we think about just the sheer numbers that we see when it comes to squamous cell, depending upon the studies, you'll have equal to even more disease-related mortality in the squamous cell group. Now, because cancer treatments are really guided by the risk of metastasis, prognostic accuracy has direct implications on patient management, right? This is how NCCN manages its guidelines. It's driven by risk of metastasis. Now, unlike melanoma and breast and other cancers, cutaneous squamous cell the patient care has not been personalized to the same extent with risk predicting gene expression profile tests. And so that's what Castle went out and did. Now, realizing all this, the utility of traditional clinical pathological risk factors is limited by their low positive predictive value. Again, the staging systems are good, but it would be really great if we could further enhance those. And this is what we're talking about. Cutaneous squamous cell, these are the large, bad tumors that keep us up at night. This is a clinical challenge. And it would be great if we could identify these tumors that are at high risk for progression at an earlier stage. So how do we do that? Well, we have a variety of ways. And when you ask people across the country, you're going to get a variety of different staging systems and a variety of different high-risk factors that everybody uses. Some use AJCC, some use Brigham and Women's, some use a variety of both, and some kind of mix and match their own high-risk features. And here you can see there are some similarities when it comes to tumor size, how deep it is, what the level of invasion is. But each one has its own sort of nuance. And here's just another graphic of how we are identifying or assessing risk traditionally in our cutaneous squamous cell patients. And it's a give-take, right? You can have a broad criteria, but you're going to end up with a higher negative predictive value. Or you can narrow your criteria, such as utilizing, saying, Brigham and Women's T2B is saying that's your high-risk group, but then you're going to end up with a higher PPV on that side. However, current SCC staging fails to identify 30% or more of cases that will actually go on to experience metastases. And that's where the Decision DX SCC test comes in. And it's a 40 gene expression profile algorithm. So you have a patient with SCC with one or more high-risk factor. They'll run the Decision DX SCC test using the validated neural network algorithm, and it classifies the tumor within three different groups. You have class 1, which is low risk, class 2A, which is moderate risk, and 2B, which is high risk. So a little bit different from the melanoma test, which is split up into class 1 and 2, and then split with A and B. This one, you just have class 1 and then 2A and 2B. For the validation study, what I like to point out here is there was over 33 U.S. centers that were participating in this prospectively designed multicenter study. So this wasn't a problem that Castle came up with. This actually came from all of us colleagues who then approached Castle and said, hey, we have this issue with these high-risk squamous cells. Is there something that can be done? With 420 patients with known 3-year outcomes. Now, the overall metastasis rate in this group was 15%. That's relatively high, right? Most of us aren't seeing patients with squamous cells with that high of a metastatic rate. across the board. So that's just something to consider and keep in the back of your mind. Two-thirds of these tumors were on the head and neck, and a quarter of them were immunosuppressed. And here's the intended use card, and it's showing what the high-risk factors which high-risk factors were utilized for the DecisionDx-SCC test, right? And as an indications card, it's not to say that if you have any one of these factors, you have to or you should be ordering this test. But again, Castle cast a wide net so that they could collect all these high-risk data points and also recognize that everyone considers different factors to be high risk within their own sort of staging systems. So, Brigham and Women's, for example, doesn't consider immunosuppression to be a high-risk feature or a high-risk factor. But I would argue that, many of us, that see a patient that's immunosuppressed with other features, the immunosuppression will play a factor in how risky we think this patient is. And again, here's the Kaplan Myograph that you absolutely love to see. It really stratifies the cohorts into the three different classes: class 1, 2A, and 2B. And this is metastasis-free survival. So you're getting great differentiation, which is what you want to see. For the class 1 group, it was less than half of the actual metastatic risk for the group. For the class 2A, well, that was equal to many of the other clinical pathologic features that we already utilize to determine risk. Now, class 2B, well, this is just, the very high-risk group. We know that these are dangerous tumors. Get over a 50% risk of metastasis. Now let's look a little bit of this at the statistics. I hope nobody falls asleep on this part, but we'll walk you through it. It's kind of neat. So this is to show that, well, gosh, those high-risk features that were already taken to heart actually did have a solid hazard ratio in a univariate analysis. And you can see that on the left. Perineural invasion, deep invasion, poor differentiation. This is where, again, I show you the class 2A. It was right up there with those other features. So when you see a class 2A result, it's the equivalent of seeing a perineural invasion or deep invasion or poor differentiation. What's great is that held true on multivariate analysis, but you notice perineural invasion actually fell off. That's not to say perineural invasion isn't important, but what really likely happened is that goes along with some of the other features, such as deep invasion or poor differentiation. Now, what about the 2B result? Well, again, we know these are really high risk, and the hazard ratio is, way off on the chart there. And so we know that these are very, very risky tumors. So now what's interesting about, when you look at this on the statistics side of things, there's actually a multiplicative quality to these factors. And what that means is that if you have a patient with more than one of these, you can actually multiply those hazard ratios together to better determine a patient's risk. And at first, I was thinking, gosh, that's not the way that doesn't make sense to me. But when you really think about it, that's exactly how, our mind is thinking in the background anyways. That's how Brigham and Women's works, right? If you have one high-risk feature, well, that's pretty risky. And if you have two, well, that's even more risky. And I'd be willing to bet you have 3 or 4, well, yeah, you're going to assume that patient's even higher risk. So there is value to all of these class scores from the DecisionDx-SCC test. All right. Well, again, we're not saying that the staging systems are bad. Actually, let's compare and integrate it with them. And so over on the right, we have AJCC. Over on the left, we have Brigham and Women's. So let's just say, you like to use Brigham and Women's, and you consider a staged Brigham and Women's T2B or T3 to be what you consider high risk. Well, in that instance, the hazard ratio was 2.38. Well, how did the 40 GEP, the DecisionDx-SCC test stack up? Well, you can see for the class 2A result, it was 2.98. So even a little bit better than the Brigham and Women's staging. And then the 2B, again, we know these are just the higher risk tumors. And, you can see similarly, things worked out for AJCC staging as well. So here's just a quick chart as to how the 40GEP result may inform your management decisions within already established guidelines. So, you're going to have a patient with a high-risk squamous cell, and one or more of these risk factors, and you're going to order the 40GEP test, and we think it's going to split up into different levels of intensity, right? Low, moderate, and high. And for low intensity, and really all treatments, you're going to do surgery first, if feasible. And then you're going to do a clinical nodal exam, and that may be all that's necessary. And for moderate intensity, again, you're doing surgery, but you're considering some sort of nodal imaging or potential staging, and you may even consider an oncology referral. Now, for those that are high risk, you're doing surgery, you're doing some sort of nodal imaging and considering staging, and you're consulting radonc or medical oncology or an interdisciplinary group. Now, for follow-up, I think this really gives us a chance to refine what our follow-up plans actually are going to be. And particularly in a COVID pandemic period, this can really help refine how often are we bringing back some of these high-risk patients within our clinics. And you can also match those return visits with the surveillance intensity that you prefer. So let's go through some cases real quick here. We have a 76-year-old guy with an SCC on the cheek. It's a Brigham and Women's T2B, relatively high risk, right? AJCC8, it's a T3. 76-year-old guy with a 1.8 centimeter lesion on the left cheek. It was treated with Mohs, and it was all out, right? We cut it all out. The patient was immunocompetent, but the tumor was found to be poorly differentiated on histology and invasion beyond the sub-Q fat. And that's an important fact, is that sometimes we don't, usually we get incomplete staging at the time of biopsy. And so it's not until you actually go for the wide local excision or the Mohs that you'll actually be able to really better understand a patient's risk for squamous cell. Now, for this patient, unfortunately, they had a regional metastasis 4 months later that was treated with Mohs, and then they got cetuximab. But they were also a class 2B. So, I would ask and say, well, gosh, if you had known that this patient was a class 2B at the time of Mohs, the initial Mohs, was there anything different that you could have done? Maybe you'd increase the surveillance of the nodal exam, or consider imaging, or perhaps even consider adjuvant radiation therapy. Another case, we have an 89-year-old guy who has a 4 centimeter lesion on the scalp. It's a Brigham and Women's T2B, was treated with wide local excision, no residual tumor, but there was perineural invasion, large nerve, and deep invasion was found. The patient was immunocompetent. This patient had no problem. 3 years later, no recurrence, no metastasis. Now, this patient also had a DecisionDx-SCC result that was a class 1. This was low risk. Now, was there anything in the management with this patient that we could have done differently? Well, I'd like to say that some patients might have treated this patient with adjuvant radiation therapy. So in this case, that was foregone. But if you were considering something such as radiation therapy, would this test make you reconsider your management decision? And here are the cases side by side. You can see relatively similar patients with that otherwise would be Brigham and Women's T2B staging and AJCC8 T3 staging that have vastly different outcomes that were predicted by the DecisionDx-SCC test. And so the question is would the addition or knowing these GEP results at their initial staging, would this have changed their management and potentially led to improved care? And that is the end of the hour. Thank you so much for your attention. I really appreciate it. Here is my email. I welcome all questions. I think we're having a question and answer after this. Look forward to joining everyone in Wisconsin, hopefully sometime soon. But go Bears!